If you're active or take care of people who are active, then you've probably heard the term tendinitis before, right? That term's a little outdated, as I'll explain here in a little bit, but it proves the point that tendon problems are very common. Today we'll talk all about them, so let's dive in. Thanks so much for stopping by, everybody. I really appreciate it. My name is Jordan Rennicke. I'm a dual board certified family and sports medicine physician. And the goal of this podcast is to help keep you active and healthy for life through actionable evidence-informed education. Thanks so much for stopping by. I really appreciate it. Today, we're talking all about tendinopathy 101. So the basics of tendinopathy. What is a tendon? How does tendinopathy present? What actually causes it? How to diagnose it? And how we think about treating it. So let's get started. First, let's talk a little about tendon anatomy and biomechanics. So looking at anatomy here, it's kind of complicated, but stick with me. I'm going to try to keep it on kind of a 20,000 foot view. But so it can be really nuanced. I mean, there's people who do their PhDs in tendinopathy and tendon research. So people can nerd out about this. I've been nerding about it recently, but I'm going to keep it kind of higher level, just generalize some things. But we're going to talk about some anatomy because anatomy always helps to understand that. So first things first is inside of the kind of unit, there's these tenocytes, right? So there's a certain type of fibroblast cells, and they make this extracellular matrix, which has collagen fibers in it. And typically in the tendon is predominantly type 1 collagen. So more like rope-like, dense connective tissue. When I think of collagen, I think of really strong, right? Type 1 is a strong collagen. It's organized into microfibrils in parallel, well-organized, densely packed fashion. So if you look down here in the picture, you can just see how everything's kind of in a line, right? In a line, in a line, in a line, in a line. That's really densely packed, nice and organized. That looks like a good, solid tendon. And we then have these fibers are in parallel, right? So if they're in parallel, then they're wrapped by an endothelium, which makes these fascicles. Then these fascicles are bound by an epitenon, and the whole tendon is enclosed by fascia, and the space between the fascia and the tendon is called the peritoneum. So kind of step back here, we have collagen, and then we are organized into different fibers, and then fibers are in parallel, and they kind of make a fascicle, and then fascicles are wrapped around in fascia, and in between them is kind of called the peritoneum. For our purposes, I just want to let you know, there's a very well thought out structure here to tendons. It's not just specifically like, oh, it is what it is. No, they're very well organized. They're in a nice, dense, fiber, like really well laid out and organized. And it kind of has this pattern. And specifically for us, it's just important to know that there's a lot of stuff going on. Collagen is important, well structured. The thing I want you to take home is it's really well organized. And there's an area called the peritoneum, which is between the fascia and the tendon. That could also be potentially important as well. But just understanding that we typically, when we're looking at it, nice and organized, that's the big thing of a healthy tendon. And from a biomechanical perspective, tendons are great at absorbing load and using load. So a lot of them, it depends on where they are. They can kind of have elastic properties, but they're more of like a tensile strength when you think about it. They really are really strong. Like when you push on them, you think about the patellar tendon, the Achilles tendon, when the forces that are transmitted through them, they can absorb a lot and they're very strong. And they can also help kind of absorb that and then transfer that energy as well. But that being said, not all of these tendons are the same. The Achilles and the patellar are thicker and more of like a shock absorbing type thing. That's kind of how I think about it. Whereas something like the rotator cuff or the glute medius tendon on the greater trochanter, those aren't so much shock absorbing. They're kind of working with mobility, but some of them, the big, huge ones, like the Achilles specifically, are really good at absorbing that energy and transferring that energy. And so that is something we think about. And there is a unique property to the tendons that they are good at storing that energy and kind of help absorbing it and then giving it back and transferring it, but they also can handle lots and lots of tensile strength. So that's kind of thinking about our just general over anatomy and biomechanics. Then talking about pathophysiology of a tendinopathy. There's a few ways here. Specifically, the biggest thing we think about is repetitive use injuries, right? So when someone is doing some over and over, that's the biggest thing. So this is an overuse type injury. Occasionally you can have excessive compression, meaning let's say like you took to the back of your Achilles, like something just whacked you like a ball or something like that. That could cause a tendinopathy just from a acute kind of compression on there. But usually that is not the most common way. It can happen though. You can have like overall compression, like maybe you just have really, really tight fitting shoes and that's compressing the Achilles over and over again. And so that can happen, but most of the time it's overuse. And when we have a combo of overuse and pushing on, our tendons really don't like that. They specifically do not like being stretched and compressed simultaneously, which that makes sense, right? That's intuitive. They don't like that. But the biggest thing I really want you to think about is the reason that we have most of tendinopathies is an overuse, right? It's kind of a mismatch. So we'll have different factors, meaning the volume someone's working out, the intensity, the frequency, that some combination of that is not right, and that's leading to overuse. So when you think about volume, that's like how much you're doing, intensity, how hard you're doing it, or frequency, how often, how many times a day or a week or whatever you're doing it, that is it. And there's some magic dose for every person that gives you like the right balance of just enough stress, but not too much. And so finding that is a balance. But there's also some general risk factors for tendinopathy, meaning age. The greater your age, the more likely you have that, just because as we age, everything seems to be a risk factor for pretty much everything. But genetics may play a role, your sex, different local cytokines, biomechanics, how you walk, body composition, lots and lots of things may affect it. And so overall, there's lots of things that may happen. But generally, if you think about it, the takeaway is most of the time, this is coming from an overuse syndrome. So someone is kind of, using more than they usually are, and that's it. And that kind of brings me to the concept of load, and that load matters. When I mean load matters, it means like this is the biggest thing we talk about here. Load can be anabolic or catabolic for tendons. And the general saying I say is tendons like load. They like it, but it's kind of like this Goldilocks principle where they have to have the right amount. So when I say it's anabolic or catabolic, what I mean by that is too much load can be a problem. But the right amount of load is great because it gets stronger and builds and adapts to that. It's progressive loading that we talk about all the time with rehab and resistance training. When you're getting bigger, you need progressive loading. Same thing with tendons. They want to be progressively loaded. They like load, but it has to be just right. They're kind of divas. It's got to be the perfect thing. All right, so now we've talked about load. Let's move on to the tendon pathology model, how we kind of think this all works. So this is a somewhat confusing diagram. I'm going to go through it here, kind of explain what's going on. It is a little complex, but we'll go through it one by one here. So if you look at the middle here, this normal tendon, right? This is where we'll start. This is a normal tendon. Nice, fibular, compact. We've talked about that. That's what it looks like. But we can have this stress shielded situation. This is where we're kind of offloading. This is what your body naturally does when it hurts. This is, hey, like I'm kind of in a lot of pain and I'm going to baby it. And your body, your tendon specifically do a really good job of saying, hey, like using it hurts, so I'm going to offload it. So stress shield is not a position we want to be in. That's saying, hey, we're babying a little bit. So that's if we unload it. Then we optimize it back, say, hey, let's get some going there. We get back to our normal tendon potentially. But from here, we can go a couple of different ways, right? So if you look at, we'll go to the right here first. We have an optimized load, right? So we talked about the right dose at the right time. Get an optimized load of the tendon, leads to an adaptation. It strengthens it, still stay normal. That's great. This is the cycle right here we want to stay in, where we're just constantly loading it appropriately. This is a well thought out rehab or introduction program. Like if you're getting started to run, just starting with your return to run program, we don't want to just jump you in too fast. We're hopefully having a progressive way in there to help optimize things, to have adaptations to grow. That's like overall, like this little circuit is like resistance training and rehab in a nutshell. Like give it optimized load, have adaptation, get stronger. That's it. So that's a really important circle. That's what we want. But sometimes that does not happen. Maybe we have excessive load or different risk factors that leads to something called a reactive tendinopathy. So reactive tendinopathy is the next stage where we're saying, hey, there's something going on here, and we'll talk more about the actual pathology. Usually it's saying, hey, we're starting to see some swelling in the tendon. It's just not, usually we have pain here potentially. It's not doing well, but it's just more short term. Like this is like initially like, hey, the first presentation is someone having some sort of pain. Like I just started my basketball program. I'm trying to jump and dunk, and now my knee hurts. And it's the patellar tendon. This is kind of that reactive where it's the first phase of that. So that's that. And then if we continue to have excessive loads and aren't appropriately having adaptations or modifying it, it can lead to this tendon disrepair. You can see though right here from this reactive tendinopathy, if we give a modified appropriate load, we can get back to that normal tendon, and it's not long-term and forever. And that's important to know that we can actually go back and revert to our normal tendon. Doesn't mean necessarily there's long-term damage to the tendon. But whereas if we think about down here, once we get past reactive, if we keep adding to it, like we're just like, nah, I'm just gonna keep jumping, hooper's got a hoop, and we go all the way down to tendon disrepair, then we start seeing long-term tendon type changes here. And then long-term is degenerative tendinopathy, where it's just like we have a chronic issue, degenerative changes. We'll talk more about what that looks. There's, instead of, if you think about the nice compact fibular thing, a lot of times they have potential disorganization, not necessarily tears. We might see smaller things on ultrasound. You'll see some hypoechoic spots, not as bright. So this is like the overall model saying, hey, we start here with our normal tendon, and too much load kind of gives us a warning saying, hey, reactive tendinopathy, this hurts. Usually the acute phase. When it becomes a little more chronic, then we start going into tendon disrepair, but that's not like the worst. And then we get into degenerative, where from here, it's going to be long-term for sure. And as you notice, as we move further down here, it's harder and harder to revert back to a normal tendon. And that's just talking about morphology. So that does not necessarily mean pain. So that's the big take home point here is you could see on ultrasound, I ultrasound a bunch of people's tendons where it looks awful, right? It's just like, oh my gosh, that's really, there's black spots on the ultrasound. It's really thickened. It looks bad. There's different neovascularization. There's all this stuff going on, but they have no pain. So like at the end of the day, you can be at any stage here and not have pain. And so that doesn't necessarily mean we have to, worry about it, but these are higher risk of rupturing if you get down into degenerative tendinopathy. But you can meet any of these situations right here and not necessarily have pain. But a lot of times you won't have pain with a normal tendon. It's going to be in one stage there, if that makes sense. And so That's like the big take home of this. It's kind of confusing, just like the 10 and the 20,000th of view is that we have a normal tendon, can then go get irritated and get more irritated and more irritated until eventually you can't return it. And that's like the general idea of, the pathology. And when I talk about like visual depiction of that, one thing I think about is like a donut model. So a donut and a donut hole. A lot of times when we talk about, when we get to that degenerative changes, we start seeing a little bit of, maybe some holes, like quote unquote holes. It's not necessarily what, but on ultrasound, you see dark black spots, which is just meaning, hey, we have disorganization there. And a lot of times we think about it as though we have that spot, but then around it, the rest of it is robust tendon. And so it's not like the entire tendon is gone and just ratty, nothing like that. So we typically have a healthy part of the tendon, but degenerative portion inside. So it's kind of this donut and a hole theory. And so what your body actually does, very intuitively, is it says, hey, we have this issue here, and then they start building out additional tendon around it. And so it gets more robust. And there's some data showing that people who have even, pretty nasty appearing areas of their tendon, they actually make additional tendon or have bigger increase. I shouldn't say make, they have hypertrophy of the rest of the tendon, and it gets bigger and stronger, and it kind of makes up the load, right? So it's like, hey, we're picking up the slack. And so that's a way to think about it, is kind of this donut and hole thing. And when we think about tendinopathies, there's also different locations we can have, right? So we can have mid-tendon or insertional. Mid-tendon is a lot less common. Usually we think about the Achilles here. So we call it a mid-substance. So if you think about the middle of the Achilles not attaching to the bone, that's mid-substance. That's going to be the prime example of this, whereas the much more common one is going to be the insertional. And insertional is where it's attaching to the bone. So we can also have insertional Achilles, but think about patellar tendinopathy. You can either have it at the tibial tuberosity or the inferior pole of patella, or a lot of times it's where it's attaching the bone. That is more common for sure. And then when we talk about these locations, we also have clinical categories. And just like we talked about before, right, we have reactant or early tendon disrepair. So if we go back to that continuum, right, you think about reactive is that first stage, and then tendon disrepair is that second stage. Those are kind of like, we lump them together because it's still pretty early. It's not too late. Whereas we have late tendon disrepair or degeneration, as well as the other category we can fall into. So once we get to here, we're saying, okay, this is a little more chronic, a little more severe. And so these are the clinical categories of how we think about it. A lot of times these are going to be more, reactive early tendon stuff is still, like I said, relatively acute and maybe new, and trying to offload those to get people back might be the way. But treatment wise, can have a little differences there. But once again, load is the biggest thing. And so speaking of, treatment, let's first get into how we clinically present, right? So typically this is an insidious onset. So like I said, typically, usually insidious, meaning chronically happened over time. Not many people are like, yeah, I was jumping and all of a sudden, like one jump, my knee just really started hurting. If that is the case, that's probably not a tendinopathy. That's probably something else we look into. But usually it's insidious, kind of comes on over time. And usually this comes with some increase in activity. The vast majority of times we see this in someone who's like, hey, I'm starting up this running regimen, or I'm increasing my volume. Usually I'm here, now I'm doing more. I'm training for a 5K, I'm training for a marathon. I started jumping more. What something is, there's usually some spike in activity. That's the biggest thing on history. Like if I had to give like one takeaway for history, like really pin people down, like what have you been doing? I just saw someone today with, greater trochanteric pain syndrome on the hips. And I was kind of getting the history in there saying, yeah, I've started running again. That's a big thing. I haven't been running in a while. Now I'm running. And I, did a ramp up over 2 weeks. And it's like, okay, that 2 weeks might be right for some people, but for other people, it may be too quick. And so usually some type of increase in activity is a big thing. And a lot of times it's worse to start, meaning, hey, it's really sore when I start working out, but it gets better when I get moving wrong. And then like towards the end, it hurt and it might hurt the next day. And that's the big thing, is maybe this kind of like warm up phenomenon where like you start warming up, feels better, and then it gets worse again. That's pretty classic for tendinopathy. They'll also complain of pain when using the tendon, but not at rest. So that's kind of the big thing. If you think about not at rest, if I can like highlight that right there, not at rest. Tendons do well when you offload them, right? So if they say, hey, I've actually been like resting it and it feels really good. Yeah, like that happens when you don't load them. They feel good, but then right when they use them again, that's when they have pain. So that's something we think about. And then also they may have tendinous palpation on the tendon itself or at the insertion where it inserts, if it's insertional kind. So insidious, kind of gradually came on, worse with using it, maybe gets better, a little warm up. And then they also may have pain the next day. That's a big thing, is that, hey, like I was feeling good, I pushed it, and then I was howling for multiple days or a day after. That's a very classic presentation as well. If we talk about imaging real quick, ultrasound is kind of the first line for this. When we do this in the clinic, what I'm typically looking for is, does someone have thickening of that? A lot of times we might see thickening of the tendon first. That's kind of the big thing. And then we may also see some vascularity or disorganization next. So when I mean vascularity is when you use ultrasound, you put on color. You can look for like vessels pulsing, and you'll see new formation of blood vessels in the tendon. And what that is indicating that this, neovascularization, your body's trying to essentially say, hey, there's something going on here. We need to create more, blood vessels here to bring nutrients and healing stuff and whatnot. But long story short, that's a indication that there's something going on. And then you also might just see that disorganization, right? So we talked about how it's really nice and tight, and on ultrasound it may look not quite as tight. You might see some black spots in there. It looks overall thickened. And then if it's real bad, you can just when it's that final stage of degeneration, you just see lots of anechoic spots, disorganization everywhere. That's kind of the big thing on ultrasound. But that's really subjective, right? If we think about it, ultrasound is me using it. And that's Jordan Rennicke saying, hey, okay, this is what I see. And someone else might be like, no, I don't see that. That's a little different, or me to read it a little differently. So it's not the end all be all by any means. It can be nice to corroborate. In terms of x-rays, there's no real utility for using x-rays in this. And then MRI can be helpful for hard ultrasound spots if you can't get there, or if you don't have the capability for ultrasound. But you certainly do not need imaging to make a diagnosis of tendinopathy. If you have the history of the insidious onset on examination, maybe they have some tenderness or palpation, or you provoke them. That's the thing. They're going to have pain on their exam with provoking, meaning let's say it's their patellar tendon. If you get them into a squat, do some sort of squatting, that's going to load that. That's probably going to hurt. If they have Achilles, you do some sort of, raise, you go up on their toes, that's going to hurt them. So using that tendon in a resisted fashion typically will do that. If you have that and maybe some tenderness palpation and history, you can make the diagnosis of a tendinopathy. You do not need imaging. And quite honestly, I think it's not worth it to refer someone just to get imaging to make the diagnosis, because that is pretty classic what it is. And one thing I do want to mention as well is that pain-wise, it does not correlate well with imaging. This is another reason why I don't encourage you to necessarily go out and get imaging for a tendinopathy, because it doesn't correlate well. About 2/3 of tendon ruptures had no pain before the incident. They've gone back and looked at the tendons afterwards and said, yeah, there's lots of degenerative changes. So they had pathology, but they didn't have pain. But there's also plenty of people who have, maybe not quite as extreme and have some pain. And so it varies. And so you just can't necessarily say, oh, wow, look how bad that looks, and they might not have pain. It doesn't mean they're not at increased risk of other things happening like rupture. That is the case. If you have degenerative tendon, you're at a higher risk of having rupture, but it's not the end all be all. And so that's why we treat patients and not images. And that's the biggest thing to understand, that you may see some pathology with no pain. And that's a good thing to know, because then we may have to work on kind of strengthening that area to hopefully prevent injuries, although that's very hard to do. But it's not one for one. If I ultrasound someone's Achilles and they have no pain, I'm like, oh, look how bad that is, because I don't want to, I don't want to no-see of them and say, hey, oh, I should be scared now, I should have pain. And that's not the case. So if we talk about treatment, there are lots of treatment. This is going to be a kind of tough one, and we'll kind of dive into this more later. But generally, we think about early reactive or early tendon disrepair. Load management's the biggest thing. We've talked about this over and over again. So load management, the intensity, duration, frequency, type of load. Tendon load without energy storage and release. So meaning, things like cycling, strength training are pretty well tolerated. Meaning if we don't have that energy storage release. So something like running, you got to store a lot of energy, release it. And that's a big thing. Whereas if you're cycling or strength training even isn't store and release, it's pretty constant. That probably won't cause further pain. But it is probably best to avoid high elastic or eccentric loading right away when it's really reactive. We'll get to eccentric loading eventually, but right away, just kind of back off a little bit. But we do want to have some progressive kind of loading there. NSAID data is mixed in terms of histology changes, meaning if it makes changes or not, but it can help with the pain, and it may prevent further tendon swelling. And one thing I do want to mention is, we used to say tendinitis, right? So tendinitis, it's inflammation. We found that it's not really inflammatory in nature, meaning causing the pathology. Yes, there is some inflammation there, no doubt, and some swelling, but that doesn't seem to be the underlying problem. It's kind of like this load structure we talked about and can lead to that disrepair. And so the NSAIDs aren't necessarily going to fix anything, right? They might take away some pain, and that's okay. There's definitely a time and a place for that. But the days of NSAIDs and taking rest those days are over for tendons. So that's not the thing. Tendons load, they need load, but NSAIDs may or may not help with the changes in terms of if it's just a little bit reactive, getting it back to where it is. I think of it more of hey, we're treating their pain, not treating the underlying pathology. That's going to be our load management. That's what's in progressive loading. But NSAIDs do have a time and place when we are really irritated, and that's okay. It can be part of a rehab program. And then when we get into late tendon disrepair or degenerative tendinopathy, when it's kind of a little further along, here We're having treatments to stimulate cell activity, meaning specifically a lot of it's going to be we're aiming to try to restructure the matrix, get stronger. That's going to be progressive loading. There are other things like extracorporeal shockwave therapy, prolotherapy. Those are things. PRP injections are mentioned once again. But like at the end of the day, what's the underlying problem from these tendons, right? It's a load mismatch, and then we have disorganization of the tendon. And so we're trying to get that tendon more robust. And anything passive that we do isn't going to necessarily help the tendon. You know, we talk about shockwave, prolotherapy, injections. Steroids certainly won't do that. It might help with the pain, but underlying this problem is a load issue. So we need to get them to properly load. And so that's why exercise therapy is so important. That's like the last thing I just wanted to mention here. Exercise therapy, there's a couple main ones that we talk about. We talk about eccentric versus heavy slow resistance. Both of them work well, and the correct loading dose is the most important thing. When I mean correct loading dose, I'm just saying like, hey, we want to load this person appropriately and progressively. And when I mean progressively means like, hey, we start with a, 10 heel raises, right? For something on the Achilles. And then we move to 12 and then 15, and then we add weight and we just progressively move them there. And when I say eccentric versus heavy slow resistance, what I mean by that eccentric is when I think of like a bicep curl. When you have curled up and you're slowly going down, that's the eccentric. Eccentric is lengthening while contracting. Isometric is just contracting with no movement. And then concentric is when you are contracting and shortening essentially the muscle. So that's concentric. So bicep curls, concentric's up, eccentric is slowly down, isometric's just holding it. And it seems that the eccentric or heavy slow resistance work well. And heavy slow resistance is a combination of concentric and eccentric. So essentially what that would be is you are just slowly going up on the activity and slowly going down. Whereas eccentric, all you're doing is essentially slowly going through that lowered portion, and then you can go back regular from the concentric. And both of them work well. I think the data is probably moving a little more towards heavy slow resistance, meaning just that's easier for people to understand. It's like you don't have to worry about focusing quite as much on a specific side, but both of them can work well. What's the common theme? They are loading the tendon. That's the biggest thing. They are loading the tendon. So overall tendinopathy, going to be insidious onset and associated with some sort of spike in activity, most likely on exam. It's going to hurt when you load it, maybe tender palpation as well. We treat these with load, the right amount of load. So getting them into physical therapy or a home exercise program, or just understanding their loading dose is important, but do not offload them entirely. Tendons like load. And treatment wise, the biggest thing is progressively loading them. That's the big takeaway there. So hopefully that was helpful. That's tendinopathy. But thank you so much for stopping by. If you listen to me all the way, I really appreciate it. If you're here at the end, I mean the world if you share this with someone. If maybe someone has tendinopathy or treats them and you think this might be helpful, that would mean the world if you could share this. Or if you left a 5-star review on your podcast app of choice, that would mean a lot. Now, thanks for stopping by. Get off your phone, get outside, have a great rest of your day, and we'll see you next time.